Welcome to the Funnel Effect.
It's great to be back.
Today we are taking a massive swing at one of the most contentious, high-stakes debates in all of modern cardiology.
That's not an exaggeration either. This is a big one.
It really is. We're looking at a condition that sits right at the intersection of, well, simple plumbing and incredibly complex physiology. It's a topic that has genuinely divided the medical community for decades.
Well, absolutely. It pits that urge to, fix something immediately against this mountain of evidence that's been building, suggesting maybe we should just wait and medicate.
Exactly. So for today's deep dive, we are tackling the source material titled Revascularization in Ischemic Left Ventricular Dysfunction, a pathophysiology-guided, evidence-based approach.
It's a mouthful of a title, I grant you. But the implications are, frankly, even heavier. This is really about life and death decisions for the heart's main engine room.
We're talking about the fundamental question of how we treat a failing heart when its fuel lines are clogged up.
That's the core of it. What do you do?
And before we get into the gears and pistons of the physiology, we absolutely have to credit the architects of this analysis. This is a state-of-the-art review, and it's a massive collaboration.
It really is a who's who.
We're talking Matthew Ryan, Alexander G. Truesdell, Gavin J. Murphy, Saad M. Azad, Stephen Frames, Alexandra J. Lansky,
Elmer Omerovich, Stephen Windecker, Eric J. Velasquez. I mean, you see a name like Velasquez, you're talking about the definitive trials in this space.
And it keeps going. Mark C. Petrie, Ajay Kurtain, Greg W. Stone, and Devaka Pereira.
That is essentially a roll call of the heaviest hitters in interventional cardiology and heart failure. When you see names like Stone and Pereira and Velasquez on the same byline, you stop what you're doing and you pay attention.
It is an all-star team. And just for context for you, this work was published in JCC, Cardiovascular Interventions, Volume 18, number 24, just back in December of 2025.
So this is not dusty textbook history. This is the bleeding edge. This is how we are thinking about treating failing hearts right now.
It's the synthesis of, maybe 20 years of confusion into something that looks like a coherent strategy. It's the guide for the next decade.
I think so.
So let's set the stage. The clinical problem is ischemic left ventricular dysfunction, or ILVD. Now, to the layperson, that sounds like a bunch of medical Scrabble tiles. But to a patient, this is a terrifying diagnosis. What are we actually dealing with here?
We're dealing with a heart that is failing. Specifically, the main pumping chamber, the left ventricle, is failing because it has a lack of blood supply. It's the most common cause of what we call HFrEF.
Heart failure with reduced ejection fraction.
Right, HFrEF. And that reduced ejection fraction part is key. It means the pump just isn't squeezing out enough blood with each beat.
So what's a normal squeeze versus a bad one?
Well, a normal, healthy heart squeezes out about, say, 55 to 70% of its volume with every single contraction. In ILVD, we are often talking about numbers below 35%, sometimes even below 30. Yeah. The engine is just completely misfiring. And the suspected cause is that the coronary arteries, the heart's own fuel lines, are blocked by atherosclerosis. Plaque buildup.
And the stakes here they're incredibly high. This isn't just about being a little short of breath when you climb a flight of stairs, is it?
No, unfortunately not. The mortality rates for ILVD are significantly higher than for what we call non-ischemic cardiomyopathy.
So if your heart is weak because of, say, a virus or a genetic issue, that's bad.
That's bad. But if it's weak because of blockages, you are, statistically speaking, in much deeper trouble. You are prone to malignant arrhythmias, sudden cardiac death, and just progressive pump failure. It's a very, very precarious ledge to be standing on.
And this brings us right to the central conflict of our entire deep dive today. Historically, the logic used to treat this was incredibly linear. It was almost mechanical.
It was the plumbing theory. That's what everyone called it. And it goes exactly like this. The heart muscle is weak because it's starving for oxygen. The oxygen is supplied by blood. The blood is blocked by a narrowed artery. Therefore,
if I open the artery, the muscle gets oxygen, the muscle wakes up, and the heart gets strong again.
Exactly. If I open the artery with a stent or a bypass graft, problem solved.
It makes perfect intuitive sense. I mean, if my garden hose is kinked, I unkink it and the water flows. If my car's fuel injector is clogged, I clean it and the engine purrs.
And that very simple, very powerful intuition drove medical practice for 40 years.
Yeah.
It was dogma. If you saw a blockage in a weak heart, you fixed the blockage.
You just fixed it. No questions asked.
No questions. We assumed it saved lives. In fact, it felt negligent not to fix it.
But then the science did what science does. It got annoying. It got complicated.
It got very messy. We started running these large-scale randomized trials. Not just observing what happened, but actually testing the theory against a control group. And the results, they were a shock to the system.
What did they find?
They suggested that fixing the plumbing doesn't always fix the pump. And even more controversially, it doesn't always keep the patient alive longer.
Which brings us to our mission today. We are going to deconstruct this paper to understand why the plumbing theory failed. We're going to look at the sort of war between the major trials, Stitch and Revived, and finally map out the modern decision-making framework.
Because it turns out the answer isn't fix everyone or fix no one.
It's about finding that specific patient who needs the plumber versus the one who needs the pharmacist.
It's precision medicine. That's the goal. We have to move away from that one-size-fits-all approach that we relied on for so long.
Okay, let's start with part one, the physiology. Why is the heart failing in the first place? The paper makes a really crucial distinction right at the beginning. It says ILVD is not binary. It's not just alive or dead.
Correct. And if you view the heart muscle as a light switch, just on or off, you're absolutely going to mistreat the patient. The authors describe it as a spectrum of dysfunction. There are 3 distinct states the muscle can be in.
And they can all be happening at once.
Yes, often simultaneously in different parts of the same heart. It's a patchwork.
Okay, let's walk through them. The first one they talk about is stunning.
Stunning is exactly what it sounds like. I want you to imagine a prize fighter taking a massive right hook to the jaw. He doesn't get knocked out cold.
But he's wobbling.
He's wobbling, he's dazed, his coordination is gone, he's still standing, but he can't fight effectively.
Okay, so how does that translate to the heart?
In the heart, stunning happens after a transient episode of ischemia, a temporary lack of blood flow. Maybe a small clot formed and then dissolved on its own, or maybe the patient exercised too hard and the demand for oxygen outstripped the supply.
And then the blood flow comes back.
The blood flow returns to normal, reperfusion happens, but the muscle function stays depressed. It's like a metabolic hangover. There's often calcium overload inside the cells, and the contractile machinery is just, it jammed.
So the fuel line is open again, but the engine is still sputtering?
Yes. The perfusion, the blood flow, and the contraction are uncoupled. But, and this is the absolute key, if there's no further insult, no new damage, stunning recovers. It wakes up all on its own.
How long does that take?
It just needs time. Sometimes days, sometimes weeks.
Okay, so that's the short-term issue. What about the long-term adaptation? The paper talks about hibernation. This sounds like what bears do in winter, but I assume the heart isn't just sleeping through the season.
It's a remarkably similar concept, actually. Hibernation is fascinating because it shows just how intelligent the body is. Imagine you have a coronary artery that's, say, 90% blocked. The flow is a trickle.
Not zero, but not enough.
Right. It's not zero, so the tissue isn't dying immediately, but it's nowhere near enough to support a full, vigorous contraction. The heart is running on fumes.
So it has to make a choice?
Exactly. The heart muscle faces a choice. Keep trying to pump hard and burn out, which would lead to cell death, or downregulate. It chooses to downregulate. It effectively puts itself into power save mode.
Like my laptop when it hits 10% battery, the screen dims, the background apps all close down?
Precisely. The muscle stops contracting to save energy, specifically to maintain the crucial ion pumps that keep the cell membrane intact. It sacrifices function to ensure survival. That is hibernation. The muscle is alive, but if you look at it on an ultrasound, it looks dead because it isn't moving.
But this is the state we can fix, right? Theoretically, this is the one where the plumber is the hero.
In theory, yes. This is the very cornerstone of the entire revascularization logic. If you can restore that blood flow, if you bypass that 90% blockage, the muscle should say, aha, the fuel is back, and then exit power save mode. It should wake up and start pumping again.
Okay, but then we have the third state, the one we can't fix.
Infarction, the scar. This is necrosis. The tissue's been starved for too long, the cells have ruptured and died, and the body replaces that beautiful contractile muscle with fibrous scar tissue.
And scar tissue doesn't pump.
It does not pump, and it does not consume oxygen. It is inert. Once you have a transmural scar, meaning it goes all the way from the inside wall, the endocardium, to the outside wall, the epicardium, it is game over for that specific segment of the heart.
Irreversible.
Completely irreversible. No amount of blood flow will ever bring it back.
The complexity, as the paper really hammers home, is that a patient doesn't just walk in with a sign that says, I am hibernating, or I am scarred.
No, not at all. A single patient's left ventricle is often a patchwork quilt. The anterior wall might be scarred from a heart attack they had 10 years ago. The lateral wall might be hibernating because of a tight blockage in a different artery. The inferior wall might be stunned because they ran for the bus this morning.
So when you look at the overall function, that low ejection fraction, you really have no idea how much of that weakness is permanent scar versus potentially reversible hibernation.
Exactly. And that makes predicting the outcome of a surgery or a stent procedure incredibly difficult. You might go in and fix the artery, but if 80% of the muscle it feeds is already scar, the heart's not going to get any stronger.
There's one more concept in this physiology section that I found really important and frankly a bit confusing at first. This idea of causal versus bystander disease.
Ah, yes. This is a huge diagnostic trap, and it catches even very experienced doctors. So we see a patient with a weak heart. We do an angiogram, we look at the arteries, and we see blockages. Our brain immediately wants to connect those two dots.
It's the smoking gun, A causes B.
Right. The blockage caused the weakness. But sometimes the blockages are just innocent bystanders. The patient might have a primary genetic cardiomyopathy, a weak heart from birth, or maybe they had a bad viral myocarditis. But because they're 65 and eat a Western diet, they also happen to have some coronary artery disease.
So the blockages are there, but they aren't the reason the heart is failing.
Precisely. So if you go in and stent the arteries in that patient, you accomplish nothing for their heart failure. You're fixing a problem that isn't the cause of the symptoms. The failure is intrinsic to the muscle, not because of the supply.
The paper mentions a tool to help distinguish this, right? The BCIS Jeopardy score.
Yes, the British Cardiovascular Intervention Society Jeopardy score. It's a way of quantifying the anatomic risk. You look at the angiogram and you calculate how much of the heart muscle is actually downstream of the significant blockages.
So you're mapping the territory that's under threat.
Exactly. If the score is high, say above 6 on their scale, it means a massive amount of muscle is being threatened by these blockages. That strongly suggests the blockages are the cause, that this is ischemic LV dysfunction.
And if the score is low?
If the score is low, but the heart function is still terrible, it implies the blockages are minor players. It's much more likely to be bystander disease.
It's like detective work. You have to prove the suspect was at the scene and had the weapon before you sentence the patient to something like open heart surgery.
Before you commit them to a procedure with significant risk, you need to be as certain as you can be that the procedure actually addresses the cause of the problem.
Okay, so we have the physiology established, this complex patchwork of stunned, hibernating, and scarred tissue, and this mystery of whether the blockages are even to blame. Now, let's move to part 2, the evidence that shook the field.
This is where it gets really interesting.
We hinted that the trials didn't go the way people expected.
Didn't go the way people expected is the understatement of the century. The results of these trials effectively rewrote the guidelines. They turned dogma on its head.
Let's talk about the big one first, the STH trial.
STTG. It stands for Surgical Treatment for Ischemic Heart Failure. This was the first massive, definitive attempt to answer the question, does bypass surgery or CABG save lives in patients with weak hearts compared to just giving them the best available medications?
What was the setup for that trial?
They took 12,212 patients. All of them had a very low ejection fraction, below 35%, so severe failure in coronary disease that a surgeon looked at and said, yes, I can bypass that.
And then they split them.
They randomized them. Half got their chest cracked open for bypass surgery. The other half just took the medical therapy that was standard at the time.
And the result, the big reveal.
Well, when they published the 5-year results, the room went silent. There was no significant difference in the rate of death between the group that had major surgery and the group that just took pills.
Wait a minute. So you're telling me going through the trauma of open heart surgery, weeks of recovery, pain, the risk of infection, stroke, all of that provided no survival benefit over taking pills at 5 years?
That is correct. In fact, it was actually worse than that in the short term. The trial showed what we call an early hazard. In the first 30 days after surgery, more people died in the bypass group than in the medication group.
Because surgery is dangerous.
Exactly. You are taking a very sick patient with a failing heart and subjecting them to general anesthesia, a heart-lung machine, massive systemic inflammation. You pay a heavy toll up front. At 5 years, the surgery group is just barely catching up to the medication group, essentially paying back that early debt of risk.
That must have been devastating for the surgical community, who truly believed they were saving lives with this operation.
It was a huge blow. But in credit to the researchers here, they didn't stop. They knew biology takes time, so they extended the follow-up out to 10 years. This became the STICHES study, the extension study.
A long game.
The long game. And at nearly 10 years, the curves finally separated. Bypass surgery did reduce all-cause mortality significantly. 59% of the surgery group had died, compared to 66% of the medication group.
So surgery did work, but you had to survive the first month and then wait almost a decade to see the gap widen.
It worked, but with major caveats. On average, it added about 18 months of life expectancy. But, and this is a huge nuance, this benefit was driven almost entirely by patients younger than 60 years old.
Why is that?
It seems that younger patients just have more physiological reserve to handle the surgery. They survive that early hazard and then live long enough to reap the long-term rewards of the new plumbing, which is likely preventing future heart attacks.
And older patients.
Older patients. Well, often they didn't live long enough to see the benefit emerge, or the trauma of the surgery simply took too much out of them. It accelerated their decline.
So SSH taught us, bypass is a long-term investment, and it's mostly for the young and the relatively fit. But that was bypass. What about stents? Stents are so much easier, right?
That was the great hope. And that hope led to the revived BCIS-2 trial. This is much more recent history. The logic was so compelling, it was, okay, bypass has this huge early risk because it's major surgery. But PCI stenting is minimally invasive. You go in through the wrist, usually no general anesthesia. Maybe if we use stents, we get all the benefit of revascularization without that early death hazard.
It's a very sound logic. What did the data say?
The data was brutal. They took 700 patients with severe heart failure, and, this is critical, they pre-screened them to ensure they had viable, hibernating muscle. They wanted to give the therapy its best chance to succeed.
So they made sure the muscle wasn't dead scar tissue?
Correct. They then randomized them to either getting stents or getting the best modern medical therapy. At a follow-up of 3.4 years, absolutely nothing.
Nothing.
A flat line. No difference in death. No difference in hospitalization for heart failure. And here is the real kicker. There was no sustained improvement in the heart's pumping function, the LVEF, compared to the medication group.
I need to pause on that. You open the artery, feeding the hibernating muscle, the muscle that's supposed to be asleep, but the heart doesn't pump any stronger than if you just give it a bunch of pills.
Correct. The ejection fraction improved a little bit in both groups, as it does with good medical therapy, but the stents didn't add anything extra on top.
What about quality of life? Did the patients at least feel better?
Briefly, yes, at 6 months and 12 months, the stent group reported better quality of life scores. But by 2 years, that difference had completely vanished.
A placebo effect.
It was almost certainly a powerful placebo effect, that I had a procedure, so I must be better feeling, but it wasn't durable.
This result must have been a bombshell for interventional cardiologists.
It was an earthquake. It challenged the fundamental idea that hibernating muscle in a stable patient needs a mechanical fix. It basically said that for stable patients without angina, stents were essentially cosmetic.
So this is the big question we have to ask. Why? Why did bypass in this DES trial eventually eke out a win, but stents in the REVIVE trial failed completely to show any benefit?
The paper offers 2 really compelling theories. The first is a mechanical one. It's about the nature of the fix. Bypass surgery, especially when it uses an artery from the chest wall called the lima, is sewn in past the blockage. It protects the entire downstream vessel from any future disease.
So bypass is like a more complete insurance policy against future heart attacks.
Exactly. It bypasses the entire disease segment. A stent only fixes the specific tight spot that exists today. It doesn't prevent a new blockage from forming 2 centimeters away next year. No. So CIBG might be a more durable fix.
Okay, that's possibility 1. What's the other theory?
The second theory is the one that I find most optimistic for patients. It's about the competition. It's about how good the control group got.
How so?
In the SGCH trial, which was conducted in the early 2000s, the optimal medical therapy was, well, it was okay. It was good for its time, but not great by today's standards.
But in REVIVE.
In REVIVE,
yeah,
conducted in the 2020s, the medical therapy was spectacular. The drugs got so much better. We now have what we call the 4 pillars of heart failure therapy. We have RNE drugs like Entresto. We have SGLT2 inhibitors. These drugs are so profoundly effective at unloading the heart, remodeling the muscle, and preventing death.
That they close the gap.
They close the gap. They raise the survival bar so high that it becomes incredibly difficult for any procedure to show an extra benefit on top of them.
And the paper has data to back this up, right? A pooled analysis.
Yes. This is so telling. If you just look at the raw mortality numbers, patients in the modern era of the REVIVE trial had lower mortality than the patients in the older era of the STCH trial, regardless of whether they got a procedure or not.
So the rising tide of medicine lifted all boats?
Exactly. It proves that the medicines are doing the heavy lifting for survival.
That is a profound realization. It's not that stents are bad, it's that the pills have become great.
The baseline has shifted. We're treating the heart so well chemically that a mechanical intervention is becoming less and less relevant for pure survival in stable patients.
This segues perfectly into part 3, which is the myth of viability testing. Because based on everything we said earlier about hibernating muscle, any listener would think, okay, this is simple. Surely we just test to see if the muscle is alive. If it's alive, we fix it. If it's dead, we don't.
That is the logical trap. It makes perfect biological sense. And we have spent decades refining these incredibly sophisticated tests, cardiac MRI, PTT scans, dobutamine stress echoes, all designed to find this viable, hibernating muscle.
But the clinical trials...
The clinical trials shattered that assumption.
How so? I mean, how could they possibly shatter that?
In both S-Stitch and Revived, they did these pre-planned sub-studies where they specifically looked for viability. They thought, okay, maybe the whole group didn't benefit from surgery or stents, but surely the patients with the most viable hibernating muscle did.
That seems like a surefire bet.
And they didn't. In both trials, the presence of viable tissue did not predict who would benefit from revascularization.
Hold on, so having a live hibernating muscle didn't mean you were more likely to do better with surgery or a stent?
No. Patients who had viable muscle lived just as long on medications as they did with the procedure. There was no interaction. The entire theory that viability equals a need for revascularization just fell apart under the weight of the data.
That is completely counterintuitive. I don't get it. If the muscle is alive but asleep, why doesn't waking it up with more blood flow help?
It suggests a couple things. One, it suggests that modern medications are so good that they are capable of waking up that muscle, or at least compensating for it, just as well as opening the artery does, but without the procedural risk. Or two, it means that hibernation is a much more complex biological state than we realized, and simply restoring blood flow isn't the magic on-off switch we thought it was.
So is there any value to these tests then? Should we just throw away the multi-million-dollar MRI and PT scanners?
No, there's a nuance. The tests are very good for prognosis. If you do a test and see that a patient has a massive amount of scar tissue, they're going to do poorly no matter what you do. Scar is bad. It predicts death.
But you can't use it to guide therapy.
Exactly. Using the test to say, yes, do surgery on this person, or no, don't do surgery, is not supported by the evidence.
The paper is pretty blunt about this point.
It is. It states, and I'm paraphrasing here, contemporary evidence does not support using viability or ischemia tests to decide whether a patient should undergo revascularization to improve prognosis.
That is a mic drop moment in cardiology. Stop looking for ghosts in the machine to make your decision for you.
At least for the purpose of extending life. Now, if you're a surgeon using it to plan your operation to know where to sew the graft, that's a different story. But don't use it as the gatekeeper for yes or no.
So if viability isn't the filter and stenting everyone isn't the answer, how on earth do we decide? This brings us to part 4, the modern decision-making framework. Who actually gets treated?
The foundation, as we've hinted at, is GDMT, Guideline-Directed Medical Therapy. This is step 1, 2, and 3.
The 4 pillars, we keep mentioning them. Let's list them out clearly for everyone.
The 4 pillars. Pillar 1, beta blockers. These slow the heart rate and reduce its oxygen demand. Pillar 2, RIAS inhibitors. This includes drugs like ACE inhibitors, or more commonly now, an ARNI like Entresto, which relaxes the blood vessels and stops the heart from getting thicker and stiffer.
Gives too.
Pillar 3, mineralocorticoid receptor antagonists, or MRAs. These help stop fibrosis and scarring. And pillar 4, the SGLT2 inhibitors. These are the new kids on the block, originally for diabetes, but they turned out to be miraculous for heart failure.
And the paper throws out a statistic here about these 4 pillars that just stopped me in my tracks.
It is a staggering number. For a 50-year-old patient with HFrEF, being on all 4 of these drugs compared to being on limited or no therapy can add an estimated 8 years of life expectancy.
8 years from optimizing the pill box.
8 years. That is more effective than almost any surgical intervention we have in the whole of cardiology. So step 1 for every single patient is get them on the 4 pillars and optimize the doses. Don't even think about rushing to the cath lab until the pharmacy is sorted out.
Okay, but interventionalists and surgeons still have jobs. So who does get the plumbing fixed? The paper breaks it down into green, red, and gray zones. Let's start with the green zone.
The green zone, the clear go for revascularization, are patients with limiting angina.
Chest pain.
Yes, chest pain. If the patient says, "Doc, I can't walk to my mailbox without my chest feeling like an elephant is sitting on it," you revascularize them. But, and this is a critical point from the trials, you were doing it to improve their symptoms and their quality of life, not necessarily to make them live longer.
Quality over quantity.
Precisely. If the pills don't stop the pain, the stent almost certainly will. The other green zone is acute coronary syndromes. If you are having a heart attack right now or you had one last week, we fix the culprit artery. That is completely non-negotiable. The muscle is actively dying now, so we have to save it.
Makes sense. What about the red zone, the stop, do not pass, go?
The red zone is conservative management, MAIDs only. These are the stable patients that were studied and revived. They have a weak heart, but they don't have any chest pain. They might be short of breath from the heart failure itself, but they don't have angina. Revive showed us that putting stents in these people provides no survival benefit and only exposes them to procedural risk. So you spare them that risk.
And then the gray zone, this is where it gets tricky.
This is where the art of medicine comes in. The gray zone includes those younger patients, like we saw in Seposh, maybe under 60, who might get that long-term survival benefit from a bypass surgery. It also includes patients with really extensive high-risk disease, like a blockage in the left main artery, where the risk of a catastrophic event is just too high to ignore.
And this is where the heart team comes in.
It has to be the heart team. This shouldn't be one doctor in a silo making the call. You need a surgeon who is biased towards cutting, an interventionalist who is biased towards stenting, and a heart failure specialist who is biased towards medications, all sitting in a room together.
And fighting it out.
Constructively debating. They check each other's biases. And the paper makes a huge point about shared decision-making.
Right.
The patient's values are paramount. An 80-year-old might say, look, I don't want to spend 3 months of my remaining time recovering from open heart surgery.
Yeah.
I'd rather take the pills and enjoy my garden.
Whereas a 50-year-old.
A 50-year-old might say, crack my chest. I need to do whatever it takes to survive another 20 years to see my grandkids graduate. It's not just about the angiogram. It's about the person attached to it.
All right, let's shift gears. We've talked about the weather. Now let's talk a bit about the how. Part 5, planning high-risk PCI. So let's say the heart team decides this patient needs stents. Maybe they're too frail for surgery, but they have terrible life-limiting angina. This isn't a routine procedure, is it?
No, absolutely not. The paper explicitly warns that patients with ILVD are, by definition, high risk. The mortality during these procedures is 2 to 5 times higher than in patients with normal heart function. You are, in effect, working on a failing engine while the car is still moving down the highway.
And the authors introduce a concept to help manage this risk. They call it the triangle of risk.
Right. To really understand the danger, you have to look at 3 points of the triangle. Point 1, the patient. Are they old? Are they diabetic? Do their kidneys work? Frailty is a huge predictor of bad outcomes. A frail patient has no buffer, no reserve if things start to go wrong.
Okay, that's point 1. Point 2.
Point 2 is the anatomy. How messy are the arteries? Is it a blockage in the left main, the so-called widowmaker artery? Is the plaque rock hard with calcium, requiring drills to open it up? Are the vessels completely blocked, what we call chronic total occlusions? Complex anatomy means a longer procedure, more X-ray dye, which hurts the kidneys, and more time for the heart to be starved of oxygen.
And the third point of the triangle.
Point 3 is hemodynamics. This is the one people often forget about until it's too late. What is the patient's blood pressure? And more importantly, what are the filling pressures inside the heart itself?
Explain filling pressure for us.
It's a measurement called the LVEDP, the left ventricular end diastolic pressure. Think of it as the pressure inside a balloon before you even try to blow more air into it. If the heart is stiff and failing, that pressure is already very high. If a patient is walking this tightrope with low blood pressure on the outside and high pressure on the inside, one small slip, a temporary drop in flow while you're putting a stent in, can cause them to crash.
The spiral of death you sometimes hear about.
Yes. The blood pressure drops, so the heart gets less blood, so it pumps even weaker, so the pressure drops more. It's a vicious cycle that is very hard to pull out of.
So this brings up the right heart catheterization, or RHC. The paper calls it crucial. Why?
Because it's like checking the engine specs before you take the car out on the racetrack.
Right.
An RHC involves putting a special catheter into the pulmonary artery to measure the cardiac index, how much blood is actually pumping, and all those internal pressures. The authors argue you should not be flying blind in these cases.
So if you know the filling pressures are sky high beforehand, you might do something different.
Absolutely.
Yeah.
You might give diuretics before the case to try and lower the pressure. You might even decide to keep that catheter in during the procedure to monitor it in real time. If you see the pulmonary artery pressure start to spike, you know the heart is struggling. Even if the blood pressure on the arm cuff looks okay for the moment, It's an early warning system.
Another strategic point they make is about complete versus incomplete revascularization. In the old days, I feel like the goal was always to make the picture look perfect, fix every single block in
They
it.
called it the oculostenotic reflex. If the eye sees a stenosis, the hand has to fix it. But in these very frail hearts, long procedures are dangerous. The kidneys hate the dye. The heart hates the ischemia. The paper advocates for a much more strategic approach.
Yep.
Target the lesions that supply viable muscle.
In other words, don't waste 2 hours trying to open a vessel that only feeds a dead scar.
Exactly. It's all risk for zero reward, and they also advocate for staged procedures. Don't try to be a hero and do a 5-hour procedure to fix everything in one sitting. Fix the most critical part, the left main, the biggest vessel, and get out. Let the patient recover. Let their kidneys recover. Then bring them back in 6 weeks to work on the less critical vessels. Live to fight another day.
That brings us to part 6, mechanical circulatory support. This is the safety net, right?
Or protected PCI, as it's often called. The idea is simple. Use a machine to help pump blood while the doctor fixes the heart. So if the heart stumbles or stops for a moment, the patient doesn't die.
So what are the options here? What's in the toolbox?
We have 3 main tiers of support. First, there's the IABP, the intra-aortic balloon pump. It's the old reliable. It's a balloon that goes in through the leg, sits in the aorta. It inflates when the heart relaxes and deflates when it contracts. It helps blood flow to the coronaries. But it doesn't actually pump blood forward very much.
So it's more of a helper than a replacement.
Correct. The trial data on it, a trial called BCIS-1, was technically neutral on major events, but it did hint that it might help long-term survival. It's most often used as a bailout when things are already going wrong.
Okay, next level up.
The Impella, or what we call a PLVE, a percutaneous left ventricular assist device. This is a tiny turbine pump on a catheter. It sits inside the heart and actively sucks blood out of the failing left ventricle and pushes it into the aorta. It can increase the body's blood output significantly.
So it effectively takes over the pumping function.
To a large degree, yes. It unloads the ventricle, giving the heart a chance to rest while we work, and it maintains blood pressure to the brain and kidneys. The downside is it requires a much larger hole in the leg artery, so there's a higher risk of bleeding complications. The main trial, PROTECT 2, was also neutral, but again, sub-studies suggested that the highest-risk patients might benefit.
And then there's the nuclear option.
VECMO, veno-arterial extracorporeal membrane oxygenation. This is full heart-lung bypass done with catheters. You're taking all the blue blood out of the body, running it through an artificial lung to oxygenate it, and then pumping it back into an artery. It provides massive support, but it carries the highest risk of major complications: bleeding, stroke, infection. It's for the sickest of the sick.
Now, the paper makes a very, very strong distinction between elective and bailout use of these pumps.
This is the most critical takeaway for any operator listening.
Yeah.
Bailout outcomes are terrible. If you wait until the patient crashes, has a cardiac arrest, and then you try to put a pump in while someone is doing CPR, the survival rates are just dismal.
Because the damage is already done.
The crash has happened. The brain and kidneys have lost oxygen. The whole point of protected PCI is to use that triangle of risk to identify the patient who is likely to crash and put the pump in before you even start the procedure. You prevent the crash from ever happening.
It's like putting on your parachute before you jump out of the plane rather than trying to strap it on while you're already falling.
It is the perfect analogy. The consensus is, if you think you might need it, you probably need it.
Are there trials coming that will finally prove if this parachute works?
Yes, the entire field is eagerly awaiting the results of CHIP BCIS-3 and PROTECT 4. These are huge ongoing trials, expected around 2026 or 2027. They will finally tell us, hopefully, if putting these pumps in electively in high-risk patients actually saves lives, compared to just being really, really careful.
We'll have to do another deep dive when those results drop.
Oh, absolutely. Those are going to be guideline-changing papers, one way or another.
Okay, part 7, future directions and non-technical factors. I found this section of the paper really interesting because it felt very human. It wasn't about wires and balloons, it was about brains and communication.
Well, high-stakes medicine is a team sport, or at least it should be. The authors talk about the pilot and co-pilot model for these complex cases.
Like in an airplane cockpit.
Exactly. A complex PCI on a sick heart can take hours. Decision fatigue is a real phenomenon. If you're the primary operator, you can get tunnel vision. You're just staring at a tiny wire on a screen trying to cross a stubborn blockage.
And you miss the big picture.
You miss the big picture. Having a second experienced operator, A co-pilot scrubbed in and standing next to you allows for better decision-making. They can watch the vital signs monitors. They can say, hey, the pressure's drifting down. Let's pause for a minute. They monitor the hemodynamics and can step in and help if things go south. It reduces the cognitive load on the primary operator.
Check your altitude, Captain.
Precisely. And they also emphasize simulation. The best teams practice the crash. They run drills in a simulation lab on how to put in an Impello or get a patient on ECMO quickly so when it happens in real life, it's muscle memory, not panic. You do not want to be reading the instruction manual during a cardiac arrest.
They also mentioned some ongoing research like a trial called STCH3.
Yes, SCH3 is very exciting. It's finally going to compare PCI or stents directly against CBG or bypass in a modern randomized trial. Remember, SD Doherty compared CBG to meds. Revived compared PCI to meds. We've never had a massive modern head-to-head comparison of PCI versus CBG in this specific low EF population.
But that result isn't due until 2030, you said.
Science takes time. For a survival endpoint, you need long-term follow-up to see the differences emerge.
And just briefly, they mentioned HFpEF, heart failure with preserved ejection fraction.
The other kind of heart failure. The paper basically admits we know almost nothing about revascularization in those patients. The pump squeezes well, but it's stiff. It's a complete black hole of evidence right now. But trials like Reprieved are starting up to finally look at it.
And the final frontier? Genetics.
The ultimate frontier. The hope is that one day we won't just look at an angiogram or an MRI. We will look at a genetic profile that tells us this patient's muscle has the innate capacity to regenerate versus this patient is genetically predisposed to form scar. That would be the ultimate form of personalized medicine.
Okay, part 8. Conclusion. Let's bring it all home. We have covered a huge amount of ground. What are the big essential takeaways for the listener?
All right, let's summarize the key points. 1. Ischemic left ventricular dysfunction is a spectrum. It's not dead or alive. It's a mix of stunned, hibernating, and scarred tissue.
2. Routine revascularization for stable patients, just because an artery is blocked, is not supported by the evidence. The STIPT and Revive trials taught us that with a great deal of certainty.
3. Medical therapy, those 4 pillars of GDMT, is the absolute foundation of survival. It's the heavy lifter in this disease.
And 4, when we do decide to intervene, usually for severe angina or an acute heart attack, then detailed planning, a heart team consensus and a deep respect for the patient's hemodynamics are completely non-negotiable.
It's a fundamental shift from a mindset of fix everything to fix what matters and medically optimize the rest. Precision over volume, thought over reflex.
And here's a final provocative thought to leave you with. The source suggests we are still on the hunt for a kind of holy grail in this field.
We are. Right now, we're making these life-altering decisions based on shadows on an X-ray, which is the angiogram, or blurry pictures of muscle metabolism from viability scans. But the paper implies that the real answer, the true differentiator, lies in biological signals.
What do you mean by that?
There must be a molecular marker, something we can measure in the blood or the tissue itself, that sends up a signal saying, I am asleep, but I am ready to wake up, versus a different signal that says, I am gone for good, let me go.
A biological distress flare.
Exactly. Until we find that signal, we are working with imperfect tools. And because our tools are imperfect, we have to be cautious, humble guides for our patients. We shouldn't promise a cure where we can't deliver one, but we also shouldn't deny relief from suffering where we can safely provide it.
A powerful reminder of the humility needed in medicine.
Always. The heart is an incredibly complex machine, and we are still just learning the manual.
This has been a fascinating journey through the heart's engine room. We hope this deep dive helps you navigate the immense complexities of revascularization, whether you're a clinician, a patient, or just someone who loves understanding how we tick.
It's been a real pleasure.
Thank you for watching The Funnel Effect.